and tail. Can you touch your head? Show me your head, please. Touch your head. There you go. Touch your head. That's good. But because I have 2 coins, you have to touch your head with 2 hands. Okay? So these coins have got a head and a tail. Okay? So this is a guessing game. You have to guess. Okay? When I throw the coins in the air, is it going to be head, or is it going to be head and tail? This is your tail. Okay? Is it going to be head and tail? Is it going to be tail and tail? 2 tails, 2 heads, or head and tail? Are you ready? Okay, let's go. So make your prediction, make your choices now. You can choose now.
You can choose one. You can choose
Yes, yeah. So you have to be honest. When you don't get it right, you need to sit down. Okay.
Question.
Yes.
What if I'm correct on 1 point?
No, you have to be correct on both. Okay, are you ready? So make your choices, whether you're choosing 2 heads, whether you choose 2 tails, or whether you choose a head and a tail. Are you ready? Okay. I'll let you decide which one is head and which one is tail. So, okay, here we go. So this one is a tail. This one here is a head. So if you choose a head and a tail, then you can stand up. Okay? A few people still stop standing. Okay, another one. Ready? Make your choices. Is it a head and head, or tail and tail, or head and tail? Ladies and gentlemen, please make a choice. There's some people are undecided. Alright, ready? This one is, do not change last minute. This one is tail, and this one is tail. So tail is bring it. Okay. The young ladies stop standing. The 2 ladies. Alright, I can declare you winners. So let's see the winner between the 2 ladies. Alright, make your choices, ladies. Are you ready? Oh, I'll take that. I'll accept that. This one is a head, and the second coin is a head. Hey, we've got a winner. Thank you very much. So without any further ado, I would like to invite Dr. Rukundo, who is going to talk to us about ADHD, I believe, and part of it. So please make Dr. Rukundo feel welcome. Diego.
About the presentation, there is, he said that the pathology affected men, affected females than men. Why? I see in the presentation the men is high, have high number. You want your answer or your clarification. Thank you.
It's due to hormone. It's due to hormone.
It's due to hormones. I'm a hormone. Yeah. Over to you, Dr. Rukundo.
Okay. Good afternoon. So I'm back. So now I'm going to share with you about autism, and with autism I go rapidly because Professor has mentioned about autism. So I will go direct with ADHD and PTSD. Yeah, please, can you give me the slide, please? So I see now we are very few than in the morning.
What's up?
Yes, my name is there, and my contact, as we say in the morning, communication is very important. We are in digital century. Better to stay in touch. For example, this presentation I can share with everyone who wants it after. Yes, so, yeah. So, autism in Africa. Professor has said a lot about particularly the genetic aspect, the inheritance. So we have our day, an international day for autism. It's 2nd April. So the exact prevalence of autism, ASD, is not accurately documented in Africa. So there is a need of research, but it is believed to be widespread and steadily increasing. More concerning is that there is poor knowledge about the condition in Africa. So, for example, we can ask ourselves how many psychiatrists for children and adolescents we have in Africa. Very few. Here in Rwanda, even we don't have one. We had one, but it's not. Okay, we had 2, and one is still available in Rwanda. Yeah, autism spectrum disorder, or autism in common language, is a term used to describe a group of complex neurodevelopmental conditions that affect how the brain develops and works. It is marked by difficult social and behavioral interaction. So there are levels. So I said that I will not explain a lot about autism because Professor has explained it. So we have levels. There is level 1, level 2, which is mild, and we have the level 2, which is moderate. So the patient can do some activities, and we have the level which is severe. Here, the patient or the child cannot perform any activities. Yeah, so there are signs and symptoms. I remember the first time I met a child in a NERA hospital. I couldn't directly realize that it's a child who has autism. I remember he was kicking his head on the floor, but so what is wrong with him? But this is a sign of some children who has autism. I used to see their font. I used to see their hands, because when they are angry, they do this, or they kick their front to the floor. So we can see delayed speech or lack of languages. Professor told us that if a parent is educated, she can observe and say, okay, my child is different. There is something. There is not the contact. The eye contact is not there. Because imagine when you are giving birth to your child and the child doesn't see you in the eyes. You have to be, to ask, why every time when I'm with my child, he or she can't see me in my eyes? So ASD is caused by a complex mix of factors. It is plurifactorial. So there is environment factors. There are also factors when a child is born, for example, in prematurity. I remember when I was working in MENA hospital, I met many children who were premature, and some of them are now autistic children. So in Africa, many strong cultural beliefs. So the beliefs is very important too. and misinformation are widespread about the cause of autism, leading to circumstances that pose a threat to autistic individuals and their families. It is important to know that the development of ASD is complex and involves both genetic and environmental factors. Yeah, so genetics here, genes are the tiny biological component that structure our bodies and are responsible for particular characteristics that make us unique from each other. You must know that even if your child has the diagnosis of autism, he or she is unique. You have to live with that, with him or with her, as a unique person. So, when there is a problem, for example, mutation in one or many of these genes, a lot of issues arise. Different types of genes mutation, like SUV420, you see it is written there, have been found to cause ASD. So here in Rwanda, we have a genetician, Professor Leon Mutesa. So clinicians who are here, you can send patients to Professor Mutesa for this analysis of these exams. So environment is there also. My colleagues mentions here about air pollution. So we have also to put effort in climate change and see how the atmosphere is. Because if the air is polluted, we can have problem. Women who are pregnant can have children who are not born. So risk factors are there for autism. So advanced parental age, you see on the point there. So it has been shown that parents having children at above 40 years of age in women and about 50 years in men increase the risk of bearing children with ASD. I don't know if Professor is agreeing with the age and what is age of parents. Yeah. So the mom is 45, for example, 45 years old, and his husband is 60. So there is a risk. Yes. So tuzali tubyara hakiri kare. Siko bimeze. Kubyara hakiri kare. Yeah. So exposure to steroids. So steroids also can be a cause of having child with autism. So there is other, and this is very important. There is also other factors. Madame, je pense que vous gukurikira. Pregnancy complications. Abadamu bafite diabete, for example. Uratwite ufite diabete. Uratwite ufite high blood pressure, ufite hypertension. Urumva diabete cyangwa hypertension ni maladie chronique, ni indwara y'igihe kirekire. Ubwayo itera stress. Means stress ufite ishobora kujya hehe? Ishobora kujya mu mwana. So we have other conditions, early birth. I've said about prematurity. Prematurity is also a factor. Sex, there's a great sex also. Male children are said to have a higher risk of developing ASD. Abahungu bagira benshi kuruta abakobwa. So numvise ngo muri groupe y'ababyeyi bafite autisme, sinzi niba murebye abana banyu musanga abahungu aribo benshi kuruta abakobwa. Siko bimeze? Oh yes, sorry. Oh, I was asking if you are in a group, you say that you are in a group WhatsApp of parents who have children who have autism. Have you observed that male is higher than female?
Yeah,
it's true. Okay. Yeah, so the diagnosis is possible to do the diagnosis. When you're a clinician, there are, some symptoms, and we have a classification called DSM-5 and ISD. There are symptoms we can find there and do the examination. So also, these are symptoms. I think I will go up because the professor has explained about all about deficits. Yeah, so screen, how to screen. I don't know if you see the image. What is that image? This is very important. Because a child, when he has this condition, this neurodevelopmental disorder, as a doctor or a clinician, you have to ask for exams. What is this exam? What is this result? So this is a tool we don't have now in many countries in Africa. This is a PET scan. You know CT scan. You know MRI. Who knows CT scan here? So very soon, and this is good for our country, we will have very soon a PET scan here in Rwanda. So it will be good, because this is a tool that can help in the diagnosis of neurodevelopmental disorders. It helps. Urabizi ko n'abanyarwanda baba bashaka ko umuntu aca mu cyuma, siko bimeze. Iyo umuntu aciye mu cyuma uburwayi bukaboneka, birafasha, aho ukuntu bifasha umuntu ufite umurwayi. So treatment, also Professor told about it. There is an ABA, there is CBT, there is educated training, and some technologies, some devices that can help a child. Yeah, so it is important to start helping a child with autism as early as possible. Professor said about it, because their young brain is very ready to learn and grow during this time. Research has shown that when children around 1 year and 5 and 2 years and 5 years old begin therapy early, they can make big improvements in things like learning, adapting to daily life, and even in the way autism is affecting them. Yeah, also support from parent and caregiver. That is me and my son. Is not an autistic, but here I want to tell you that we have to be close to our children. Professor talked about vulture autism. So better to, if you have a child who is an old age, under 5 years, please parent, be with your children. Be with them, show them love, show them examples. So autism is different but not less. So there are some medication that can be given for some of them, like risperidone and piprazole, if the child are aggressive and in a severe situation. And of course, because they have some symptoms of depression, we can give them antidepressant. Yeah, so this is the PET scan. This is the PET scan. I was in India. That is where I saw for the first time a PET scan. So this is a machine that must be available in all Africa, in all of African countries, because it is very important. So the challenge of AIDS in Africa, we need awareness and education, diagnosis and assessment must be done by doctors, evidence-based intervention, financial support is needed, and of course, stigma reduction, social inclusion, and family support. It is not easy to live with a child who have autism, I know. So it is even a child that you cannot live with a telephone or another person to take care of. Yeah, in conclusion, autism is a complex developmental disorder that presents significant challenges for affected individuals, families, and communities, especially where services are limited in African countries. So allow me to go directly on ADHD. There is someone who asked a question about ADHD. It is also a neurodevelopmental disorder. And we have cases, we have patients here in Rwanda who have ADHD. So it means attention deficit hyperactivity disorder. That is ADHD. Yeah, so ADHD is a brain function developmental disorder that affects persons' ability to control attention, impulsivity, and activity levels. More people are now receiving an ADHD diagnosis. This is because previously it was only diagnosed in children. But now, more adults at screening are seeking help for ADHD symptoms. Yes. And there is also more awareness and less stigma around this disorder. So some research suggests that increased screen time can cause symptoms similar to those in this disorder, but more research is needed to confirm this claim. Yeah, it doesn't work, the pointer. me with the pointer. Yes, so these are symptoms. We can have symptoms of inattentive presentation. So there is difficulty sustaining attention in task or play activities, frequent careless mistakes in work or other activities, forgetfulness in daily activities. So there is also hyperactivity or impulsive presentation. So there is fingering or tapping hands or feet, inability to stay seated in situation where it is expected, so the child is moving around. Even if you put him in a class, he cannot stay on a seat. So there is also impulsive actions without consideration of consequences. So we can also have a combination of presentation. Means the child is hyperactive and is inattentive. So causes here we have family history, genetic history, as Professor said. So we have neurobiology. That is why also we have to encourage young doctors to learn neurobiology. It is very important. So we also have environmental factors, exposure to prenatal, tobacco, smoke, premature birth, low birth weight, and exposure to lead. So this is also very important, childhood trauma. So the treatment is can be available. So here we must have a holistic approach. So we can have psychotherapy, we can have some medications, we can have parental training. Very, very important, psycho-education of parents. So parental training on managing a child with an ADHD diagnosis, school support also. So we have also to teach, teachers, to be near teachers and say, okay, if you have a child who is like this, know that you can help him. There is a way you can help him according to his situation. So in African context now, although at a very slow pace, ADHD is gradually becoming more understood as a condition rather than bad behavior in Africa. Most people with this disorder struggle in school and at work because they or those around them believe that these symptoms are poor character traits. It is important to share this information with family and a friend because there are ways to have a person either resolve or cope with ADHD to live a fulfilled and productive life. So if you or someone you know may be struggling with ADHD, please reach out to a professional for help. So now it's PTSD. So we are in Rwanda, 30 years after the genocide, we have many people who have had PTSD. And let me tell you that today, they don't have the PTSD as diagnosis. Today, many of them, they have bipolar disorder. Because with the history they have had, and after that they have a stressful life. Today, many of them are on bipolar disorder. So PTSD in Africa, not only in Rwanda, PTSD is a mental health condition triggered by experiencing or witnessing a traumatic event. This is very important. It can affect anyone, regardless of age, gender, or background, and has a significant impact on daily life and functioning. So here we have symptoms like flashback, disturbing dreams, avoidance. If you saw someone who resembles people who were with you in a trauma event, or if it is a car or you meet the same car, it becomes a problem. So there are also negative changes in thinking and mood. So I say that their mood is also affected. There is also changes in physical and emotional reactions. So causes are there. While this says it can result from any traumatic experience, certain factors can increase vulnerability. Direct exposure to trauma, ongoing stress. I talk about stress. You have faced PTSD and now you are stressed. So historical and systemic trauma, occupational related risk, like first responders, military personnel, and healthcare workers. You saw war there on the picture. Here on the picture. So in how many countries today in Africa we have wars? So in those countries there are many people who are facing traumatic event. Yeah, the treatment option also is available. So I remember when we started to have in 1995, 1996 and 7, people who were who had this diagnosis. It was not easy. Even in the period of commemoration, it was not easy to manage these people who have, PTSD. But today it's different. Today it's different. There is resilience, and we say thank to our government and our policy makers in Rwanda who have been there to help survivors of genocide. And today they can have work, they live, they can have children. Yeah, so psychotherapy is needed. We can use what we call CBT and what we call EMDR. So some practitioners, some psychologists are trained to do EMDR. And EMDR is helpful for people who have a PTSD. So there are also medication. As I said, many of them today, they are on a mood stabilizer. But if they are not in a condition that is bipolar disorder, if it's depression, you can give an antidepressant and something for anxiety. I used to give also a medication used in high blood pressure called propranolol. So 40 milligrams per day, it is helpful for people who have PTSD. Yeah, so support group and peer group is very important. Yeah, engaging with others who have experienced similar trauma can help. So I still have 7 second cases of PTSD are increasing, and there is a need of research. So no health without mental health. Yoga or vodka, it's up to you to choose, please. And murakoze cyane.
Thank you.
It was a speed.
It's a race.
It's a race.
Thank you so
But
much.
I think I was clear and explained well what I have to share with you. Thank you.
Absolutely. Thank you very much. First question in terms of ADHD, is there a diagnostic tool for adults in Rwanda? Because we know adults can be diagnosed with ADHD.
Yes, we have for children, but if it's an adult, not yet. On my side, I have never met here in Rwanda a person who has a diagnosis. It's most likely children. Yes.
And on PTSD, I think, like you alluded to the history of our country, the sad history of our country.
Yeah.
So I think when we're talking about the traumatic events that people might have witnessed,
Yeah.
we just put trauma in one big umbrella,
Yes.
right? But then under that big umbrella, then there's things, things,
Yeah.
conditions like PTSD.
Yes. Yes.
Just to finish as well, the peer support.
Peer group is very important.
Yeah.
Because when you are in a group and you realize that in the group people have faced the same situation as yours, it's easy to share how they manage their situation. And if you are not alone in that situation, somehow in the mind it helps you. It helps you to say, okay, I'm with someone, another person also has faced this, and we don't have to think about the past. We have to see the future, and that is what the government of Rwanda did. To give work, to give occupation for people, tell them how they have to consult psychologists every day or once or twice per week, and the way we also commemorate today is very different with the way we commemorated in the 90s or 2000. So this is a combination of knowledge, because Rwanda is not the first country that faced traumatic events. We have, for example, in US, people who are veterans of America, they are the ones who are have experienced trauma events in wars. So here in Rwanda also we have learned about those countries, and today I think we're doing a great job for people who have faced trauma.
Thank you very much. Tumushimire Dr.
Welcome.
Thank you. Ibibazo mumbabarire. Mumbabarire tugiye gukomeza. Our last, but certainly not least speaker is Dr. Dawn. and she's going to talk to us about management of febrile convulsions. Thank you very much. Welcome. Hi. Okay. Thanks for all that are staying here late and to hear the talk. Although I'm going to talk mainly not so much about the management of febrile seizures, because I really wanted to convey some things about certain syndromes that I think are important to recognize and knowing that these can be implemented in the educational curriculum for neurology residents and also to give certain perspectives. And I just want to make sure that this goes forward. I think that one of the things I've learned is that there is a certain gap which we will hopefully narrow in the next few years as far as what is the burden of epilepsy in sub-Saharan Africa. And we do know that we do have in sub-Saharan Africa a lot of patients with epilepsy. We have infections, perinatal infant cells, traumatic brain injury. And I think that I'm very happy that with all of your colleagues, and especially with Professor Pisani, who's advocating for epilepsy surgery in Africa, because a lot of patients have hypoxia, asphyxia, prolonged labor, and then they develop even many years later. The lucky ones develop hippocampal cirrhosis that can be cured with epilepsy surgery. And I'm going to talk about some of the patients that are not as lucky. I came around this article which was just published recently from South Africa, and basically stating that we do have strategies that we can look at and diagnose things. So, how does febrile seizures go into this talk? One of the things that you can recognize is patients that have prolonged febrile seizures, and some of those patients actually have genetic abnormalities, and one of them is Dravet syndrome. And you can look and see Dravet syndrome and Lennox-Gastaut syndrome, and Lennox-Gastaut syndrome, just to tell you, is like a syndrome where it's a basket full of many etiologies. So think about all the perinatal hypoxias you have. You'll have a lot of patients with Dravet and a lot of patients with Lennox-Gastaut syndrome. We'll start talking about Dravet syndrome, and I know that genetic diagnosis may not be extremely common or easy to find here, but if you look at certain clinical syndromes, and you can see that there are many patients with Dravet that have here. It's given not a lot of time, but basically I think it's important to recognize that a lot of the first seizures are febrile seizures. And a lot of the patients initially have normal development, so a lot of them have a variety of development. But anytime you have a patient with prolonged febrile seizures, think about also Dravet, and Dravet is important, and it's important to recognize those syndromes before we have developmental slowing, because time is brain, time is development, and the earlier you institute treatment is more important. Now we do know that there are adults with Dravet syndrome, just in case, for those of you that are adult neurologists and epileptologists, and sometimes you may have cognitive impairments, Parkinsonian features. I'm going to skip some of those slides. If you have access to genetic testing, and it's important to recognize you have limited resources. Which patients should I send for diagnosis? I'm not going to go too much into the NAV 1.1 and the GABAergic things,
But you can look at what are the interictal findings and what are you look at EEG, because a lot of places do have access to EEG. So it's important to recognize that what are the high yield patterns, febrile convulsions, which may be hemiclonic. So anytime you have a patient with hemiconvulsions, think about Dravet syndrome. And then I think I brought some examples of EEGs that you can see, and these are some of our patients. And then and this is like I looked for an ictal pattern, and this was like referenced here, and I can give the reference later. And you can see that there's a focal onset and then later followed by it. But if you have a normal EEG that does not preclude Dravet syndrome, and the EEG is a tool and it shouldn't replace. And one thing I've learned coming to some and following some physicians here in Africa, in certain other countries, is that all of you have great clinical skills, great history taking, great physical diagnosis, and sometimes, I think that in the States, a lot of people are spoiled, and they forget about the importance of the history, physical, and all that. MRI is normal, so even if you have hemiconvulsions, MRI, due to lack of time, I'm going to skip. I'm just giving you just classic vignettes: 9-month-old, prolonged febrile hemiclonic seizures, EEG normal, MRI normal. Think about what things. Another key point is that I know that there's very limited anti-seizure medications, and I'm so happy that due to the efforts of a lot of you, they've added to the necessary medication list levetiracetam from the WHO. But I think it's important to know most of the medications that are available in Africa are sodium channel blockers, and sodium channel blockers are going to make it worse. So if you see the seizures are getting worse with treatment, think about Dravet and think about what you can do. Again, other things are clobazam, which is known, and I think that cannabidiol, whatever form you can have, we use like Epidiolex. And then in the US, we use a lot of fenfluramine, which is fen, which used to be used for weight loss, but that requires monitoring with echo and looking at cardiac echo because there's pulmonary hypertension. I've only seen one case reported in the literature post-marketing, so the risk is very low. It's only because you use like 10% of the doses. Yesterday we had an excellent presentation about ketogenic diet, and there's some studies that report even 15 to 30% seizure freedom with ketogenic diet. If you can't do the regular ketogenic diet, which is a 4x1, you can also try modified Atkins diet, so don't despair. I love carbs too much. I don't think I'm a very good candidate for a ketogenic diet. So I realized the importance. And this was like, there was like a symposium, so they put what is the management of Dravet. But those patients have a lot of status epilepticus. I'm not going to go too much into stereopticol, which if you go to meetings. So this is an algorithm, but some patients don't respond, and I don't exclude doing vagal nerve stimulation. I can't underestimate the importance of doing multidisciplinary care and having protocols and preventing all that. I think what's important with treatment is to know the patient's develop, really pay attention. You control the seizures, you may arrest the developmental delay, which I think is very important. And all of us have SUDEP patients, especially those that treat with epilepsy. So the risk of SUDEP is quite high in patients with Dravet. And that's something like that. There are people who are looking up and studies, looking into antisense gene therapy, antisense oligonucleotides, and there's some trials looking in that direction. So if we go into Lennox-Gastaut, which is another type, and there are many patients with LGS, and those patients may start with infantile spasms and then progress. What's important is sometimes you may see in clinic a 10-year-old, 12-year-old, and you don't see the typical EEG findings. What you see in those patients is just diffuse slowing, and that's something that is very important. So just because somebody stopped having infantile spasms does not mean that they don't have Lennox-Gastaut syndrome. Some patients have Dravet, some patients have metabolic reasons, so there's a big spectrum of those patients. And those patients may have tonic seizures, atonic seizures, atypical absence, generalized tonic-clonic, and they may also have a lot of times EEG, which is not that clear. I just showed here the classical EEG pictures of patients for LGS, which shows like a classical slow spike and wave of 2.5 hertz. You may see some paroxysmal fast activity during sleep, and that's like sometimes you can see. And then even in adults or in teenagers, you may still see sometimes during the seizures what you see here, a slow EEG, high amplitude wave, and then an sort of what looks like an electrodegramental response to generalized paroxysmal fast activity. Again, clinical EEG is important, and think about Dravet and think about what you can do. We don't have access to all the medications, and before I had access to a lot of the new medications, I used valproic acid and Rogaine for a lot of the patients with Lennox-Gastaut. Now, we can also use cannabinoids, CBD, fenfluramine, it's also approved for it. And people are looking into other medications like citalopram and other things. And the main marker of those clinical trials are drop attacks. Ketogenic diets is also effective in those patients, and especially with drop attacks. A lot of patients respond to vagus nerve stimulation. We do corpus callosotomy in some of those patients. For those of you who have access, you can either do it either with open resection or in some centers, I know in advanced centers in Morocco, Egypt, South Africa, there also may have access to lit, and you can do like non-invasively. Because a lot of people, especially people are afraid of doing cesarean. There's the problem of cultural barriers and fear from surgery, so those are things to consider. We are doing a lot of patients with LGS or LGS plus. We are targeting the central median nucleus of the thalamus and doing either deep brain stimulation or responsive nerve stimulation with those patients. We have data on like something 40, 50 patients, which is one of the largest groups available. And again, because initially I was talking to some students, just looking, drop attacks, get cognitive, and that's when slow spike and wave, that's when you can do. And again, time is brain, early recognition, and even if you don't have access to anything, you have all the clinical skills, better than a lot of the residents that I see back home, and you can not easily, but you can diagnose. But I think that what's important is SUDA and developmental. So those are things that I think I'm going to go skip over this due to lack of time. And I just wanted to briefly, another syndrome that I think is clinically recognized. A lot of you see a lot of patients, and there's a big patient load of patients. So I did want you to recognize a syndrome that is maybe treated by steroids or other stuff or surgery, and recognizing it, and you can recognize it clinically. It says that people turn in 60 seconds. They're less. Is that because of the time or that? So those patients have, what's unique about translucent encephalitis is that it is chronic inflammatory focal encephalitis. So a lot of the patients will have focal status, but if you see a patient that comes to you with twitching, focal status, and you see hemiatrophy on one side, think about translucence. I'm not going to go too much into the immunopathogenesis, and we're talking about cytotoxic CD8 and T cell, and there's a subset of patients that have glutamate receptor antibodies, but you may have either rare or more frequent things like that. So I just wanted to bring you some MRI examples from the patients that I've had. We've had it at UCLA, and you can see here, what I want you to look is that you can start seeing, and this is an actual a patient of mine, that you can actually start seeing atrophy, and the atrophy increases over the years. And look at this patient, and you can see that there is more unilateral involvement. So anytime you see a patient with focal features, focal seizures, even epilepsy episodes, and you see MRI that shows hemiatrophy, think about translucence. And this is an example of a patient that we treated, and you can see how this is a progressive disease. So I think recognizing it is very important. We have access to PET scans, so you can also see hypermetabolism on the PET scan, which is unilateral, and this is like that. There is a differential diagnosis. You may have patients with perinatal strokes, continue having seizures, focal cortical dysplasia, and encephalitis. I think, how much time do I have left? 0. I was given 20 minutes.
Not that 20 minutes, maybe another 5 or 7 minutes.
Yeah,